Dr. Fulmer, welcome again, and the floor is yours.
And thank you so much for that warm and generous introduction. And I want to express my gratitude to the Planning Committee, especially Valerie and Linda, and thank Dr. Good for his participation today. It's a very strong statement when a CEO joins in this conversation. And having been on your campus, I've experienced personally just how incredibly active and vibrant the community is around improving the experience of aging. So I'm grateful to be here with you. I'm seeing many of my friends from over many years, Mark in particular, and just delighted to be with all of you today to talk about the creating an age-friendly environment and ecosystem. When I'm in Salt Lake or in Utah in general, when you're there, what you get a sense of is we can do this. And it's a wonderful feeling. And if anybody's going to do this, it's Utah. So thank you for having me. And I look forward to getting your feedback today. Next slide, please. We are a private philanthropy based in New York City, and our money came from the A&P grocery store legacy. And the founders said that we should do the greatest good for the greatest number. In the 1980s, the trustees decided to double down on aging, and they've transformed the way education, practice, and research has moved forward, and I'm very grateful to be here. Next slide. Our mission is to improve the care of older adults. We like to say that we take the science that's been generated by the National Institutes and really put it into practice. And our three priority areas are creating age-friendly health systems, which has been underway since 2015, and you're well aware of it in your community. Supporting family caregivers. There are about 44 million family caregivers in this country saying, what do I do now? And also improving serious illness and end-of-life care, which should not be conflated. They are different and they are important, and they are something that we're very, very committed to. Next slide, please. This is a slide that's been the same since I started my work in geriatrics in the 70s. And it always goes like that. And what I would add to it is that our aging demography is rapidly becoming more diverse. And the complexity is increasing with very complex conditions such as dementia. One need only look at the $3 billion budget for the National Institute on Aging and look at the proportion of dollars that are dedicated to dementia science. Disability, social isolation, which we saw in heartbreaking ways during the pandemic and beyond. So, and the social determinants of health, which impact the way older people live every single day. The other thing we know about older adults is that they suffer a disproportionate harm and have higher rates of health care related harm and discoordination in care. Anybody who has a relative knows this. And also we are not good at preparing for disasters. Here we are again in Puerto Rico watching older people with no electricity or any capacity to take care of themselves. So we really need age-friendly solutions, and that's what I'd like to talk about today. Next slide, please. The challenge, and Dr. Good mentioned it, is ageism. Ageism has a negative impact on our health. There's science to prove that. And we all need to redefine aging by emphasizing we instead of they. Aging is the accumulation of experience and knowledge, and Linda Fried at Columbia School of Public Health likes to say it's the only naturally growing resource on the planet. And what we have to do is think of it as a natural progression, not something fixed and not something that trends in clumps. It's an individual experience. This is a group that we've funded called Reframing Aging in Washington, D.C. They give people language that takes away from the ageism. And we more recently funded them to do something called Reframing Nursing Homes. And I urge all of you to look at it because we can't talk about nursing homes as death traps and expect anybody to get on board with helping us. I'm very passionate about our nursing home work. It's not the topic today, but please look at our website. And yesterday there was a special subcommittee hearing that I recommend to all of you about the crisis of nursing homes and COVID. Next slide, please. So the challenge is that older adults and their families face a confusing landscape. Resources for older adults often exist, but consumers don't know about them. It's hard to know who to trust, and information that does exist often lacks first-person perspectives of the older adult it's meant to serve. And we'll talk about that more in a couple of minutes. But I think that to say it's a confusing landscape, I'll give you an example. Several years ago, it was 2016, we went to Florida to talk about creating a partnership between age-friendly public health systems and our area agencies on aging. And in that meeting, if you imagine a conference room with the aging people on one side and the public health people on the other side, the entire day, the conversation went like this. I had no idea you were doing that. I had no idea you were doing that. And there was a major breakthrough in that moment. And Florida, along with another 12 states, are doing a beautiful job with age-friendly public health systems. Next slide. We work with an organization called agefriendly.org, the Age Friendly Institute, and they're a nonprofit consumer-facing website that helps older adults and caregivers find and review age-friendly programs and ask the questions, is your community age-friendly? Is your local hospital? Is your assisted living facility? And so that website is one of our consumer-facing opportunities where we try to really engage people in helping us point to locations of excellence and improve locations that need improvement. Next slide. The challenge then is that our age-friendly practitioners, whether they are practitioners in universities or whether they are practitioners in clinical sites, work in silos. And so as I rolled up to this work, and to remind some of you the history, it was in 2006 that the World Health Organization started talking about age-friendly cities. And that was great. And then AARP became the anchor organization in the United States a couple of years later to create the narrative around age-friendly communities. Following, we had an age-friendly employer effort in age-friendly universities, which is doing very well, along with our age-friendly health systems and our age-friendly public health systems. But what's missing is the mechanism for listening and incorporating the voice of older adults and unifying and elevating all things age-friendly so we can accelerate adoption across the life continuum. Next slide, please. So we had a very exciting convening where we got together a multi-sector initiative with all the silos I mentioned a minute ago to create an accelerated age-friendly narrative. And we just published a paper on that, which I can chat in a little bit, or Jennifer will chat in because she's listening with me today. So age-friendly practitioners are doing transformational work in cities, communities, universities, health systems, employers, and public health all around the world. But we are working with partners now to develop a shared language that describes what it's meant to be age-friendly in all settings and provide a framework for cross-sector collaboration, action, and measurable impact. And that is important. So this particular graphic is, you're welcome to it. Put a Utah label on it and move it forward, because anything we do is open source, and we hope you'll just continue to improve it. One of the elements that's missing on this slide is our dementia-friendly communities. And we know that, and it's included in health systems, but should be called out explicitly. Next slide. So we had a series of convenings hosted by the Age Friendly Institute, the International Longevity Center, and funded by us in 20 to 2021 to identify how different sectors characterize age-friendly practices, introduce how those different sectors measure age friendliness, and agree on a set. We wanted to get to agreement, and we did, on a set of shared characteristics that define an age-friendly ecosystem. Next slide. So our goals were to make the substance behind the moniker age-friendly clear. It's easy to say it, it's hard to do it, and you have to measure it. So enhancing our collective impact on quality of life for older adults depends on working together. And we wanted to collaborate on a shared language and create a set of harmonized measures to open up new possibilities. And so that's a project that we're really proud of. And again, we invite you into it so that you can help us improve it. Next slide. We began with the building on the social ecological model with multiple levels of influence in units of practice. And this is well known to many of you who have seen this particular ecological model, where we look from the individual through society for the ways in which we all join together. Next slide, please. We had 2 very intense meetings, and the people who were with us were from WHO, the United Nations, senior level faculty and investigators and legislators from around the country. And what we did was we listened carefully to their thoughts about some pre-data we sent them, synthesized their feedback from the first meeting, revised the shared characteristics that we heard from them, reconfigured them, and created a taxonomy. And when I say we created a taxonomy, I want to call out our fantastic Columbia University interns who are with us every single semester, who work so diligently on this project, along with Jiho Chang here at the foundation. Next slide. The key takeaways from our meetings was that you could get a group to generally agree on 6 shared characteristics. We had a beginning understanding of shared goals for what an age-friendly ecosystem can deliver. There was reluctance to specify priority measures for each goal this early in the conversation. Thank you, Jen. And also, and in that paper, you'll see the members of the expert committee, and also requests for a complete measurement compendium building on our work to date, which we have since completed. It's always a work in progress. So that's what we learned in meeting 1. We were looking at data and struggling. It was a struggle meeting. And then in meeting 2, we had breakthroughs that really helped us come to some shared agreements and understandings. Next slide. So we created a draft age-friendly taxonomy and identified 6 outcome measurements. And the domains were grouped in similar outcomes, and the outcomes are explanatory concepts, and the indicators of way are measuring our desired outcomes. And I'm still very indebted to Kim Dash at EDC, Education Development Center in Waltham, Massachusetts, for the way that she moved us forward in this measurement taxonomy. Next slide. So this is from our website, and actually if you take a screenshot there, it'll take you there. I'm always surprised when these work. And so the Age-Friendly Ecosystem Compendium measures are on site at the agefriendlyinstitute.org Compendium of Measures. Why am I mentioning this so repeatedly? It's because I want every scientist in this audience to pick it up, make it better, and tell us where it's not working. Next slide. The agefriendlyinstitute.org welcomes that. And again, there's that measurement and what we want to do with it. There is a video here, which I won't show at the moment unless it goes easily. You can click on it. It's Jody Hsu talking about this work, but let's see if it works. And always the volume's a problem. There's the volume problem. So we're going to pause that. And if we can't fix the volume, I'll ask you to watch it when you have time to do that. There's a feature or a function that often creates that kind of hiccup.
Of an age-friendly ecosystem.
There you go. So we'll start at the beginning.
goal of this project has been to...
Thank you.
Hello, my name is Jody Hsu, Executive Director of the Boston-based Age-Friendly Institute. Thank you so much for your interest in this newly released Compendium of Measures of an Age-Friendly Ecosystem. The goal of this project has been to collect in one central place the various measures being used to track outcomes of interest associated with age-friendly practice and found in existing age-friendly frameworks. At present, the compendium contains over 130 measures drawn from an exhaustive review led by Dr. Kim Dash and our team here at the Institute, who surfaced measures from age-friendly practice frameworks, including age-friendly cities and communities, age-friendly health systems, age-friendly public health systems, age-friendly employers, and age-friendly universities. Our research was supplemented by a review of measures found across a wide variety of additional resources that are outlined in the introduction to the document in sheet 1 when you download it. I'd like to take a moment to walk you through just a few features of the compendium. So I'm going to share my screen with you now. First, you'll note that each row associated with column B lists one unique measure found in our review of age-friendly practice and frameworks, and its accompanying measure source, which you can find in column C. In column E, we identify whether or not the measure includes data that is available for public use. In other words, whether or not each measure has data attached to it that program managers and researchers can access. In column G, we identify the frameworks from which the measures surfaced during our research. Perhaps this will prompt some new thinking about opportunities to measure impact in collaboration with partners from across age-friendly settings. Moving back to the left-hand side of the document and column A, our working group aligned each of the measures we uncovered with one of the 6 characteristics of an age-friendly ecosystem. I'll stop here for a second to provide some context about those characteristics. In 2020 and 2021, more than 50 leaders from over 25 organizations and 6 countries who are working to advance age-friendly initiatives in public health, health systems, community, academia, and employment came together to discuss shared characteristics and measures in their work. Together, our group surfaced shared characteristics, or ways of describing a multi-sector age-friendly ecosystem. We employed a carefully structured process to draw out those characteristics so that they would be recognizable to practitioners across settings. From this work emerged 6 shared characteristics of an age-friendly ecosystem, which we describe as responsive, healthful, engaging, equitable, active, and respectful. Recognizing that practitioners want and need flexibility in how to assess progress in efforts to live up to these characteristics, alignment with specific measures helps provide a roadmap. For example, if you want to quantify the presence of responsiveness in the age-friendly ecosystem where you're working, you could look to measures outlined in rows 2 through 10 as a way to do so. Practitioners will rightly pick and choose appropriate measures for their own work, and hopefully you'll help us add to this compendium. We've made a good start by pulling down and organizing measures currently assessed by those various age-friendly frameworks, but we have work to do. Looking ahead, we'll continue to add measures to this collection. We welcome your feedback and your ideas to build upon this work and look forward to hearing from you. Thank you for your interest and for listening.
The one and only Jody Shu. I just love her, and she makes it so accessible. So I'm glad we got her volume up so you could hear her. Next slide, please. So examples of age-friendly in other sectors, and a little bit of my screen is gray. I don't know if it is for other people, but examples of other sectors include the Certified Age-Friendly Employer, what they call the CAFE program for the Age-Friendly Institute, which really is leading the credentialing program for employers, marking its 15th year. So they have been at this, Certified Age-Friendly Employers, for quite some time. And they find that it helps augment diversity, equity, and inclusion efforts, reduces turnover, retains older staff, messages commitment internally and externally, and also helps learn about retirement strategies. Next slide, please. So consumers look at it and say job seekers save time by applying to employers where they're more likely to be hired. And policymakers say it's making it easier for people, for people to work longer and improves the economic security and health and reduces Social Security and Medicare burden. So it's been very successful and interesting to all governors, I might add. Next slide. The next steps for the Age-Friendly Institute are to continue engagement with all who have shaped this work. They have committed to being a hub for our continued efforts, and updates on progress are welcome on their website. One of the things they did in their first year, they worked really hard, really fast, is they put a marker up for every hospital in the United States, and on it, you get to claim your page, and it will indicate whether you are certified by IHI as an age-friendly health system. The next thing they did was the same thing for all 15,000 nursing homes in this country. And so people are going to it, they're looking at it, and what are we trying to do? We want consumers to say, are you an age-friendly health system? Because I deserve age-friendly care. So it's quite momentous what's going on. Next slide, please. Well, why again do we need age-friendly care? Because we have the models. We have the evidence-based geriatric care models that have proven to be very effective, yet they reach only a small portion of those who would benefit, because sometimes there's difficult in disseminating and scaling, difficult in reproducing in settings with less resources. It may not translate across all care settings. So in partnership with the Institute for Healthcare Improvement, I am so grateful to them. We have made it our business to take those wonderful models and spread and scale them around the country and around the world. We're now in over 40 countries. I'm on my way to Doha, Qatar next week, and I can't really believe it. But anyway, we're working around the globe. Next slide. So age-friendly systems, and as we said, we're building a movement. So all care is age-friendly, guided by the essential set of evidence-based 4Ms, causing no harm, and making sure we're consistent with what matters to older adults and their families. Next slide. This initiative, again, I want to underscore our partners from IHI, the American Hospital Association, and the Catholic Health Association of the United States. Next slide. And the essential set in our age-friendly healthcare work is the 4M framework, which we believe is absolutely important and strategically useful no matter where your care is being given and no matter who's giving the care. So that 4Ms are a set, and all of you who look at this know that they engage with one another at all times. It's almost a spiral that's always connecting across and around. So the first thing we always start with is what matters to the older person and their family, knowing and aligning care with each older adult's specific health outcome goals and their care preferences, including but not limited to end-of-life care and across settings of care. Medications, we know that a lot of harm can come from medications. And if they're necessary, we want to make sure we're using age-friendly medications that don't interfere with what matters to the older person or their mentation or mobility. Mentation, your mood and memory, and some people also say mental health. When we're paying attention to that, we can prevent, identify, treat, and manage dementia, depression, delirium across all settings of care. In mobility, I hope we can finally stop with falls committees and instead talk about mobility progress and ensure that older adults move safely every day in order to maintain their function and do what matters to them. Next slide, please. So our goal when we started, and this came from Malik Joshi, who was then at the American Hospital Association. If you've ever worked with IHI or Malik, they want to know your goal right up front. And I said, I'd like to be in 20% of settings by 2020, and we defined it. And we met that goal. We were able to get to over 1,000 sites by 2020. And the next goal that we already achieved was we said we would get to 2,600 sites of care. And we're now it's really 2,000. I'm going to say we are at the tipping point for 2,900 hospitals, practices, convenient care clinics, nursing homes, and it's growing globally. And we learned so much from our global partners. Why can this be global? Because if you think about the 4Ms, what matters? Mentation, medication, mobility. It's language agnostic, it's culture agnostic, and by the way, it's payment agnostic. All of those things are necessary for quality of life, and that's why we think we've really tapped into a global conversation. Next slide. So Utah, in the age-friendly health systems movement, is doing a great job. You're in 13 hospitals, practices, convenient care clinics, and nursing homes. And your participation Your participating systems include those listed here, and I hope I haven't missed any, but I will tell you that you're a powerhouse. And that's as of September 2022, and probably there's even more now. And we're grateful to you for your participation, your willingness to engage with us, and your commitment to this work. Next slide. We know that we've reached over 1.7 million older adults through 4M's care, and I know it's much higher than that. Next slide. I would like to give you some examples of where you can read more about the science and evidence around health systems. The sheet on your left that says action is from the American Hospital Association. And when you go online there are a number of case studies that you can pull out and reflect on. And if you would like to add case studies, AHA wants them there. And the one to the right is on the IHI website, again, welcoming you into those website conversations and wonderful examples. And the narrative to the right tells you about the outcomes and case study examples that we're getting from around the country, and they are powerful. Next slide. This is a book that we self-published in order so that I could keep the copyright and give it away for free. I never learned that when I was an academic, but I found it very handy now because I can go ahead and it's on Amazon, but the point is it's $2.99 and all proceeds go to IHI. Why did we create this book? Because there are multiple educational content modules on the IHI website, but they can be complex. They can be hard to get from front to back. And so we put this book together and welcome again your feedback on how to make it even more user-friendly. Next slide, please. So when we think about our work, and particularly having lived through COVID, which was not the first time we saw inequities, we began a very intensive equity task force, and IHI and Kedar Mate, their CEO, has committed to equity as his #1 frame for all of healthcare improvement. And so we formed a task force, and below you see a picture of Faith Mitchell, who is a fellow at the Urban Institute, who has really helped us analyze the data we have around racial and ethnic breakdown of populations and linking our ethnic data and racial data to quality measures. Do people who are diverse have more difficulty with readmissions? Are they more likely to have multi-morbid conditions that are not treated? So we know that that's really, really important. And Faith continues to just expand that work in a way that's very, very important to all of us. So I know you're doing that where you are as well. And we welcome, again, that data sharing where you can educate all of us. We are so grateful to you. We have a growing number of stakeholders, and it's almost an error on my part to show it because there are multiple of multiples. My point in this slide is to show you the diverse array of groups that come from, whether you're at a CVS Minute Clinic or whether you're at the Hospital Association of New York State or a health center. So it's really been impressive. The VA has been a very powerful partner for us. Next slide. I mentioned CVS a couple times, and I want to just underscore my enthusiasm for all the great things CVS Minute Clinics are doing. We partnered with them very early in our work and said, CVS Minute Clinics and their future health hubs have the opportunity to be age-friendly. And they said, we're going to do this with you. They embedded the age-friendly 4M care modules in all of their clinics. They have 1,900 advanced practice clinicians, and they've already built the 4Ms into their Epic record. They're very, very committed to making sure that this work is a part of their jet stream, if you will, their workflow, and that it's easy to do at all times. And then they're in the millions of patients that they have now screened, all 4Ms. And so they have a lot to teach us. And there's a lot of content on their website. Every now and then I'll go on their site and I'll notice they have a new video or a new story, which has really been very, very affirming. Next slide. Other innovative age-friendly care programs that focus on what matters, and here are some examples, is hospital at home. It had already started with CMS waivers, but it accelerated during COVID when it was so hard to keep people safe. So we have 231 hospitals, 101 systems, 36 states, and about 328 in the hospital at home users group. That users group is where content exchange among and between clinicians, systems, government entities is very exciting to watch. They're teaching each other, of course, as they go. The Alzheimer's and Dementia Care Program at UCLA, under the very capable hands of David Rubin, has now 20 locations nationally, and they're adding up to 50 sites in their next phase, working with Education Development Center. And I was on a webinar with them earlier this week, and they had over 100 new users joining them for the Alzheimer's and Dementia Care Program, which is based on advanced practice clinicians managing dementia care in partnership with families and communities. And so that's a wonderful project to watch. And we're grateful again to that group of leaders. Next slide, please. Here are additional programs that we fund or co-fund that are all a part of the age-friendly ecosystem. We've worked with the Geriatric Emergency Department Collaborative and also with ACEP, the Emergency Department Accreditation arm of the American College of Emergency Physicians, to determine what it takes to be certified as an age-friendly ED. And we have one accredited geriatric ED in Utah, and that is at the VA at Salt Lake. And again, if my data are not up to date, email me and I will fix it because the work is going so rapidly. But this is an exciting opportunity. People say if we start with the JED-C program, does that get us extra points towards having IHI count us as an age-friendly health system? And the answer is yes. And they've worked out that measurement strategy at IHI. To the right, you see the Geriatric Surgery Verification Program, where we work with the American College of Physicians. A special shout out with gratitude to Cliff Coe at the American College of Surgeons for our Geriatric Surgery Verification Program, which is very, very rigorous and really is what you want if your older relative or friend is going to have surgery. The ability to really stop and use these measures to ensure that people come through safely is changing the way people think about surgery for older adults. Next slide, please. Well, in all of this, we certainly have to meet the social needs and social determinants of health for older people and their families. 80% of our health outcomes are determined by social factors, 80%, make no mistake. And COVID-19 exposed fragile support systems. Advancing supporting community-based services is critical through private-public partnerships, integration with health systems and health plans, and knitting together your community and public health strategies. And I noticed that you have people from your state office for aging with us today, and that's also a huge compliment. Your research and publications that you create to impact policymakers and decision makers makes all the difference when you bring data to your legislators and say to them, here is the evidence We know this changes the way people think about social determinants and quality care outcomes. And we want to partner with you, make sure that we're doing this work correctly and with all the enthusiasm we can. Next slide, please. Community and health system partnerships are also critical. We fund the U.S. Aging and its Aging and Disability Institute that advances integration, partnerships, and payment models between social service systems and health systems, which connects through the 4 M's. And payment options now exist via the Chronic Care Act, Medicare Advantage coverage for health-related social needs. And so there you see a slide that shows the crosswalk and evidence base for leadership council programs in the 4 M's. So you'll have all these slides so that you can click on the links and see which ones are interesting to you, which ones speak to you, because every person listening today is a part of the fabric that we need to move forward for an age-friendly ecosystem. Next slide, please. Creating livable communities. And if I'm not mistaken, I think Utah, correct me if I'm wrong, Mark, but Utah is one of our younger population states with a growing number of older people. Thank you for that. So creating those livable communities for all ages, certainly, but to make sure that we are looking at the guidelines for age-friendly cities, the AARP guidelines for livable communities. And we now know that there are like 660 that have been recognized by AARP across the country. And those age-friendly communities provide safe, walkable streets. You have, everybody has their story about which street is one that creates jeopardy in your neighborhood. But here in New York, it's hard for people to get across the street with the number of seconds that you have, and also with the way in which people ignore stoplights. The other threat right now in our community are bicycles that go the wrong way down one-way streets and seem to, we've created an environment here where it's more important to get your Grubhub to your place on time rather than to look out for the safety of our neighbors. So working on that. Safe walkable streets. That means streets that are also have smooth surfaces where you're not going to trip, and safe walkable streets where we have the belief that our police system is working for us and keeping us safe. Housing and transportation options, really important when you think about livable communities. And I would expect that you have some very creative work going on in your communities. We know that there's a rise in the number of groups that are using some of the special programs that we're familiar with, including programs from the YMCA, for example. And I'll give you an example of that. During COVID, we reached out to the YMCAs because we had already been talking to them about what if YMCAs did adult daycare? Wouldn't that be great? There's hundreds of them around the country. And they were very interested. And during COVID, they had to shut 95% of the YMCAs in this country. And I asked them what they were doing in that moment of horrifying upheaval. And they said that they were finding creative ways to stay connected to their older adult community. Let me give you one of my favorite examples. They did virtual swimming lessons for older people who were a part of their swim program. Can you imagine that? Virtual swimming programs. So our foundation funded them to create a white paper on the creative programs that they needed to develop and imagine during COVID, and I have greatest respect for the YMCA. Access to needed support services will continue to be a way that we knit together our area agencies on aging, our AHECs, our support services, and our public health system, and all the ways that health systems and university hospitals and universities are reaching out to their communities. Very exciting. Opportunities for all ages to participate in community life. And no Utah cities are currently listed on AARP. Let's just say they must be making a mistake. I'm sure that's wrong, but we didn't find any, and I bet you can fix that very, very quickly as well. So creating that opportunity for WHO and AARP to work with you for your communities. As a nurse, I will tell you that nothing's been more helpful during COVID than telehealth. And I really am so keen on following the legislation to make sure that after the crisis is over, that we keep that telehealth. The example that always comes to my mind is I was in a clinic at Bellevue, and like once a month they had a clinic for older women to come in for GYN healthcare. These women came down with their families. Maybe they were in an outer borough. Maybe they were on a 5th floor walk up or a 20-story building. They came down, they got in their transportation modes. Some of them were city provided, some of them were not. And they came in and the clinic was canceled. Can you imagine that? The clinic was, why was it canceled? Because they didn't have enough stock for the materials they needed for the clinic that day. I will never forget the looks on those women's faces. Telehealth could have helped with some pre-screening. Certainly you need hands-on clinical care, but it could have helped, and it could have helped put them at ease, given the fact that they felt like they were abandoned, really. So access to needed services and opportunities for all ages to participate. And I welcome you all to this narrative as well. Next slide. Dementia-friendly America and dementia-friendly communities. Well, DFA is a national network of communities, organizations, and individuals seeking to ensure that communities across the United States are equipped to support people with safe and respectful care of individuals with dementia, their families and caregivers, and provide supportive options that foster quality of life. We have about over 340 communities and about 108,000 dementia-friendly America friends. And Utah has 26 states participate, not 26 states, you don't have 26 states, you have 26 communities participating. So I want to just commend you on that. Dementia-friendly program comes to Utah, and there, I'm sure there's a leader in the audience today who can tell you more about it than me. That is something that we noted with great respect as we think about all the things you're doing to really ensure that older people get this quality of care. I mentioned, and I'll say it again, that the National Institute on Aging has a $3 billion annual budget, and a very large proportion is dedicated to dementia science. It might be basic cellular science, it might be caregiver science, but if you ever wanted to write a program grant, and all, full disclosure, I just stepped off the National Advisory Council on Aging for NIA, and so I'm much more in tune with the numbers than I might be otherwise. But there you have this fantastic opportunity to do program grants together, write the science together that helps you with people who are in the early stages or late stages of dementia and their families, they're just central to the success of that work. Next slide, please. Public health is really gaining momentum in the age-friendly movement. And we all know that our public health system in this country was largely gutted over the past 30 years, and says 50 years, rare for local, state, federal public health agencies to dedicate funding for older adults. I had a conversation with another colleague who works in philanthropy, and his point was that public health has always focused on women and children. I think that is excellent. I think that is awesome. And at the same time, you improve your capacity and your care synthesis when you include older individuals in your public health narrative. So there have been some limited collaborations with health systems and aging services in public health, and I'm seeing quite a very large outgrowth of enthusiasm. We started our public health, age-friendly public health system work before the pandemic with an organization called Trust for America's Health in Washington, D.C. And I recommend that website to all of you. Trust for America's Health is truly a huge resource for what public health can do with the age-friendly work that's underway. Next slide. Continuing on those needs for public health, we know that public health has contributed to our longevity. And now we need to add quality to those years by promoting healthy aging, reducing social isolation, ensuring mobility, making sure people have access to healthy, affordable food, and that we are ready with our emergency preparedness. Every state, locale in the country has their version of emergency, and it's just something that has to be front and center with the public health offices and in our partnerships with them. So I think that's very, very important to underscore. The next slide just tells you a little bit more about some of that age-friendly public health system work. We've had a multi-state engagement, and our pilot state was Florida for obvious reasons. And again, I told you we got in a meeting and everybody was delighted to meet each other, and we were happy to be able to convene them. And my dear friend Kathy Heyer, who has since passed, was right there in the room leading the charge. And so from that, we now have expansion states that we help fund that are noted on the slide. And we have 22 additional states in various stages of age-friendly public health system efforts. There's a group which I didn't know about before called PFAB, and that stands for Public Health, the Public Health Advisory Board. It's a national board, and they accredit programs. And so TIFA's working with PFAB, sorry for the TFAB, is they're working together to get that recognition program going, and people are really they have an enormous amount of enthusiasm. We work constantly with HHS, the Office of Disability Public Health Partnerships, the CDC Healthy Brain Initiative, the Administration for Community Living, and all 50 states included in the HHS ACL region meetings and webinars and aging summits. Our foundation has supported those summits on a regular basis. There are 10 public health regions in this country, as you know. And as we go from place to place, we've been asking them to tell us their stories about how their offices are improving the well-being and lives of older adults. And it really is inspiring. If you go to that website, you'll see webinars, videos, testimonials that talk about the creative work going on. And I will point out that some of the rural work is some of the most creative, and you would well know why. So there it is, PFAB with healthy aging. By 2026, they think that they will have accreditation capacity and that all states will be engaged. Our age-friendly public health national learning collaborative is one that is also underway, like our AHA collaborative and our IHI collaboratives. And so we know that recognition for the good work going on is something that everybody cares about, and we care about it too. We want to lift you up. So here, New York State declared itself an age-friendly public health system, and they also are working hard. Governor Hochul is working hard to create new systems and structures. They just started a brand new Office of Aging and Long-Term Care, which will be formally announced at a press conference coming up. But right now, that the whole point is to make sure that there's better coordination of care across all of the elements of care in our state. Next slide, please. So community, public health, and health system partnerships are critical. And here, again, I mentioned our U.S. Aging and Disability Institute, Trust for America's Health, and the work that's going on across the country, and some of it that, I am not aware of, and I hope you'll all chime in and let me know what else I should be elevating for all of us to learn from. We want to advance the integration of partnerships. We want to elevate healthy aging as a core function of public health, so that we can ensure that if there's a moment when people need the hospital, we will have done everything in our power to stave that off. I know there are data to say if you could just move the disability curve out even by a year or two, the human suffering would be reduced so exponentially, and the cost curve as well. So we continue to look at that. Next slide. So we believe that there's an age-friendly solution for all of us, and that it's an ecosystem that we need to collaborate together. That 880 cities has to do with a project that is intergenerational, and I haven't talked a lot about intergenerational today, but I alluded to it. It's because we know that that is so much a part of the solution as we move forward and think about all the different ways that we want to improve the support we have for our workforce and improve the lives of older people in all their settings. Next slide. So I have an ask for all of you. I mentioned that I wrote a paper on age-friendly ecosystems, and I agreed to be a guest editor for a special ecosystem issue where we'll invite all of you to this open access journal to write a paper that tells us about the success you're having in your age-friendly ecosystem work. And we're inviting voices around the world, because when I tell you that what I see going on in Taiwan and Japan and in the Netherlands, it just reminds us of how much we can all learn from each other and think critically together, even in the absence of a common payment system or common regulations. So that is something that I'm hoping I'll see some Utah papers. Next slide, please. So the Age-Friendly Initiative is a social movement that should get you back to your kitchen table. And what do I mean from that? It's that continuity of care across your life that allows you to continuously get back to where you want to be. In most cases, that's going to be home. And you all know that right now we're in the midst of an additional crisis in nursing homes in this country, where many are closing. They don't have the staff, or they're not breaking even. And we saw some particularly challenging content, which I think is appropriate, around what's going on with for-profit nursing homes. I will not paint any unit with the same brush, but to say we should examine carefully the way in which we're thinking about long-term care in this country. I recommend to you the National Academies of Science, Engineering, and Medicine report on quality and safety in nursing homes, which we funded. And that report dropped on April 6th. And right now we have an additional grant that was made to Leading Age, and they have new momentum. And Jen, if you could chat in the Moving Forward website for this group. The Moving Forward initiative is based at Leading Age, which is the national voice for not-for-profit nursing homes. And by funding Leading Age in the Moving Forward initiative, and Alice Bonner is leading that work, we are moving very specifically on the 7, Jen, yes, the article I'm talking about, and it's Jennifer Phillips who will chat that in, and it's the Moving Forward website. Thank you to Jen K. And I won't give you homework, that's for Jen Phillips. So Moving Forward is a way in which the 7 recommendations that came from the National Academy's report on quality and safety now each have a committee. There are over 200 organizations that are already participating in that. And that was really the basis for the special subcommittee hearing yesterday. And again, I commend the people who participated so nobly throughout all of our terrible trials with pandemics. But we need to remember that thinking health system means that in the event that we continue to struggle with quality and safety in nursing homes, you will not have a place to discharge your patients who are inpatients, and individuals in the community who need long-term care will not get it in a nursing home. They'll probably end up in emergency rooms. So on a positive and upbeat note, what I'll say is we know what the questions are, and great groups like you know the answers. And thank you, Jen. I know that the solution lies in creative, scrappy, restless states like Utah. And I know also that you are the first people to have a chief medical officer for Age Friendly, and that's Dr. Tim Farrell, who introduced me, and I'm so grateful for his leadership and friendship. And I'm urging him to create a video so that I can play it in all my talks. So I know he's going to do it for me. So let me thank you for your incredible attention today. I know we have time for questions. I also know that I had a couple more minutes, but I have been able to participate and share with you what I thought was most useful. And I look forward to having an opportunity. Thank you for that link, Marilyn. I look forward to the opportunity to speak with you all today. Thank you for your great work. And thank you for honoring me with this opportunity to speak to you. Back to you, Jim.
Thank you, Dr. Fulmer, so much for that inspiring address. I think it's wonderful to be able to start thinking about age-friendly ecosystems. Fits so well into the areas that we want to cover during our next couple of days. At this time, I would love to open this up to questions. So questions for Dr. Fulmer. I'd also like Dr. Tim Farrell to also be able to address any aspects of Dr. Fulmer's talk today that you feel is really pertinent to what we're doing here at the University of Utah. I also know that we have a number of individuals from across the state of Utah, from public health and our aging community. We'd love to hear your thoughts on Dr. Fulmer's proposal that we look at age-friendly ecosystems, how we can form multi-sector collaborations to make Utah and the Intermountain West as age-friendly as we possibly can be. So opening it up for questions, you can either raise your hand or post questions in chat. And please complete the very short poll that we have up on your screen right now. Thank you so much.
Dr. Supiano, we see your hand up.
Thanks. I can't type fast enough to get the question in the chat. So I just wanted to begin by thanking Dr. Fulmer for not only her presentation, but what was left out of her introduction is that Utah and the University of Utah health system would not be where we are today had it not been for Terry's visit here. I just checked, it was 4.5 years ago, Terry. And to think about the incredible progress that your leadership has brought to this movement in that short period of time is just phenomenal. So thank you, and the John A. Hartford Foundation and IHI and all of your partners for all of the work that you've invested in this, and we're grateful that it's paying dividends here in Utah, as you illustrated. So that was my comment. My question is, Terry, you mentioned that eventually there will be a public demand for age-friendly care, right? That's going to be ultimately what sustains this. The other approach, so that's kind of the carrot, I guess. The stick is from accreditation. Can you update us on, I know some of the efforts that the foundation has been involved in to work with organizations like the Joint Commission on Accreditation for Hospitals and others to build in elements of age-friendly care into the accreditation system process, so that we can be assured that when we need that care in the hospital, that it is age-friendly.
Thank you, Mark, and thank you for your generous remarks as well, as always. We have been working with the Joint Commission, Mark, and David Baker is there, and he's very aware of, knowledgeable about, and partnering with us. We think we probably have one more year before we double back with that organization. Jonathan Perlin is there now as CEO, and Jonathan Perlin used to be chair of our Age-Friendly Health System Board. So that doesn't mean that we have a leg up, but it means he has a running start at knowing what we're talking about. So we are very committed to working with them. Yesterday I was on a call with IHI, and we were talking about they used a phrase, but it had to do with the environment that you're talking about, your greater environment, all the different accreditation agencies. There are about 4 that we could be working with. So each time you do that, probably we'll start with a certification, because certifications are voluntary. When we did a survey around particularly working with modern healthcare, they said, the CEO said, yeah, we like that. We want to do that because we think it will differentiate us from other care, as long as you have honest to God evidence and you know that you're not just using the term, but that a group like IHI. So we're working on that, and I'm very optimistic about moving that forward. I think that there was a second part of that, Mark.
No, that really was just to address how this can be sustained going forward, and what the demand, what the drivers will be.
I know what you want. So we also work with WebMD and with NBC Universal. So twice now we have paid for what I call shameless infomercials. I'm very proud of them, where we go and it appears that we're on the Today Show. We're not on the Today Show, and it's clear by their label that we're sponsored. But we talk to people around the country saying, are you getting age-friendly healthcare? You should demand age-friendly healthcare. If you go on, you can get it off YouTube, and we're talking to the public there. We get a lot of uptake from that, a lot of clicks. We direct them to WebMD because we are paying WebMD to work with us so that they have a landing page on age-friendly healthcare, because the public goes to WebMD very often, or somebody will find it and take it to their relative or their friend or their neighbor. If you think of additional ways we can do that, I welcome all of your good ideas, because we need that public drumbeat to say, I want age-friendly care for me and my family. Thanks, Mark.
Terry, if I could make a comment and also a question, I'll try to kind of weave in an answer to one of the questions in the chat while I do that.
Thank you.
So Ann Asman asked how we're integrating the 4Ms in our system. And I guess the short answer is in the ways you might expect, and in some ways you might not expect. One would be through the annual wellness visit and sort of making sure that template is optimized from a 4M standpoint. I would add sort of usual care in the sense of the way that, if a patient has an appointment scheduled and we're calling them to remind them, we don't just hang up after 2 rings of the phone, thinking about the mobility and people getting to the phone. We are working on also EDI, as Dr. Good had mentioned, and building out a new hospital in our West Valley, which I think would be a great opportunity for age-friendly care. And finally, I'm working with the sort of central Epic folks on a 4Ms template that would be available for everybody in Epic, regardless of where you are, so that that information is not, especially in what matters, is not sort of hidden in one aspect that the ER doc's not going to see. My question sort of builds on all of that. You had mentioned, Terry, Medicare Advantage plans. And so when I think about all of this infrastructure that we're building, I think it's highly appealing to the Medicare Advantage plans, and also a way to ensure sustainability of the care that we want to provide. So if you wouldn't mind just sort of commenting, providing some more detail on sort of how you see age-friendly aligning with these value-based programs that I think are so critical to the success of geriatrics programs nationally.
Thank you for that. And so important to think about our payers. So I'm on a board, like a geriatric advisory board for Humana, and also work regularly with Aetna, because we think they could be first movers. Aetna is owned by CVS, so it would seem to me that they should be thinking about this very strategically. Humana labels themselves as the best geriatric care, managed care program in the country. And I have said to them, prove it. And I say it to them very nicely, and I don't say that, but I mean, show me. I'm not convinced. I haven't seen it. So they're listening, they're communicating. The other person who's on that board with me is Bruce Leff, second to none at Johns Hopkins, who is very persuasive in having them say, you know, this, you need to distinguish yourself. And if you decide to use a different strategy rather than, you know, the 4Ms and age friendly, we welcome that. Just focus and make sure that we have the metrics to show why you are distinguishing yourself. So additional ideas I welcome. And if you have a meeting you want to go to, and I'll join you.
That would be fantastic. Thank you, Terry.
Good.
Thank you so much for that question, Tim, and for describing what is happening here at the University of Utah. Terry, we have a couple of questions in chat, and then we will go, I'll read those to you, and then we also have a question from the audience. So the first one is, through reframing aging, we've learned that words matter. You mentioned, rather than to say falls prevention, that we say what?
Mobility, the mobility capacity. So mobility is really important. And if you look at the literature now, it's increasingly changing. And so if you stay mobile, and if you join groups like Silver Sneakers, I'm not promoting one over another, they're all good. But if you do Tai Chi or if you do yoga, you're helping stave off sarcopenia, which is the next wave of difficulty we're going to have in this country as many, many boomers begin to experience sarcopenia in the absence of being a bicycle rider like Mark. And, you know, just thinking about all the ways that we can help people stay mobile, stay active, and make the case for why and how, and remind them that it is a stepwise progression. Do something 1 day a week, then move it to 2 days a week, then move it to, you know, accelerate it that way. And don't be discouraged when you fall back and you're not meeting your, it's like joining Weight Watchers. You know, you just do your best and get there every single time that you can and make the progress you need. But thinking about mobility capacity.
Great, thank you. And then another question in chat is, could you also mention some of the global programs that you discussed and where we could look those up?
Sure. The locations are, there's a list of them on the IHI website, but I'll call out two that come to mind. Let's talk about age-friendly universities. That movement started in Dublin, Ireland, and they made a lot of progress and then brought it to GSA in the USA. So I think reminding ourselves that there's a lot of smart people around the world. Taiwan, several years ago, I was in Taiwan and I walked into their medical center, and there was a green line for people over 65 and a blue line for people under 65. And the green line had supports and services for older people. Do you need assistance with mobility? Do you? And it was so impressive to me to see the strategies they were using. And so I think that I participate, as probably several of you do, in the World Health Organization long-term care strategy group. And if you go to the WHO websites, some of the creativity is really quite humbling and exciting.
Great, thank you so much. And then we have Rob Entz, our director of the Utah Commission on Aging, with a question.
I did notice that label earlier. Hi, how are you?
I'm doing great. Thanks, Terry. It's nice to be with you today and nice to meet you. Appreciate everything you've had to say. I really particularly am impressed with a couple of phrases that we continually bump against, and that is when people say, particularly policymakers, I had no idea you were doing this. And getting that gap closed with the other thing you said was we make statements about things and we accept them to sort of buy into everything. And the premise here is we've got to prove it. And I so appreciate the whole compendium of measures section. It's given me some great ideas of how we start to frame better outcome provability to the policymakers, because that's very, very important. I also appreciate the fact that you've talked about silos, not just in terms of sort of the age-friendly buckets, but we've got to make sure that we're transparent with each other across academic institutions, against service organizations, because the biggest challenge may be telling the public what we're doing and helping people have access to those things. But part of the problem too is those who are doing the delivery are not talking to each other as effectively as we can be. So thank you for that. Thank you for the reframing messages, which I think are great. I helped start the Falls Prevention Alliance, and I realize now that I've got to probably go back and change that to the Mobility Progress Alliance or something like that. But and all the work that like Frameworks Institute does, it's all so critical in helping us get the right messages out there. So thank you. Happy to be part of it today, and look forward to our future partnership.
Oh, I love that. And may I ask a question back? In Utah, are you working on a master plan on aging?
Yes, actually, it's interesting you asked that, because I've
Tell
actually
the group about it. Tell me about it.
Well, in a nutshell, it kind of existed in the beginning with the commission back as far as 2005. And then over the years, as some of the folks who on this call can attest, there was sort of a disappearance of the ongoing, plan that would look forward 30 years. And part of it was from funding and staffing and other initiatives that became a priority. But I've resurfaced it with the legislature, and we've got a bill being sponsored this next year to change the statute to require that, so that our annual reporting is really reporting on our progress of how we're looking out the next 5 to 30 years. And so that master plan is in motion, and lots of folks on this group will be invited and incorporating their ideas of where we need to go with that. So thank you for asking that question. And that's definitely something we're working very, very hard on.
I love that. And we're learning a lot from different states about their master plans, certainly California in the lead, but now, just this explosion in the positive sense of the word of people saying, yeah, we can do a master plan on aging. And so I look forward to reading your progress, and thank you.
Be happy to share that with you. The SCAN Foundation in California has been a great source, and one of my former colleagues is one of their head honchos down there now. So it's been great to connect and utilize their advice and guidance.
Are you talking about Sarita?
No, I'm talking about Rigo Saborio.
Yes, wonderful person.
Yep.
That's great.
Great, thank you. We have a question from Dr. Troy Anderson from the University of Utah. Troy.
Thank you, Dr. Fulmer. One thing I wanted to shout out is I'm a former recipient of a Hartford doctoral fellowship, and thank you so much. What a wonderful gift that was, pleasure that was to participate in that program. Has transformed my career. One of the interesting things for me, particularly as I prepare to retire at some point, but what if you know of any innovative models that are addressing the complexities of rural aging, and if you know of any highlighted programs that we see many small hospitals in rural areas are closing, and I wonder if there's any of any that come to mind that where they're doing a really nice job trying to address, because out here in the West we have so much space, and I just want to give any ideas about that.
I'm so glad you mentioned that. So Ronnie Snyder, who's our program, one of our senior, she's vice president for program here at the foundation, just came back from a summit on rural health and aging, where she represented our foundation, and we will be supporting that work. I mean, personally, I know the West is as rural as you get, but I grew up in a town of 300 people upstate New York, where the closest hospital is an hour and 10 minutes away. And every day you just say to yourself, how will we keep these critical access hospitals alive? And how will we create the public health infrastructure to support people in communities where there can be some dire consequences for lack of access? The other thing I'll say about rural is, and when I was dean of the College of Nursing at NYU, I was responsible for a course called Rural Nursing. And the students were in Manhattan, obviously, but we sent them to Tupper Lake, New York in January. So if they were skiers, that worked out, but if they weren't, they were freezing. But there was a 50-bed hospital there, and it was critical access, obviously, still is, the Adirondack Medical Center. And the students, I could only send 10 at a time, but they would blanch at what they'd say, Dean Fulmer, do you know what we're allowed and expected to do in rural sites? And I said, yes, and now you know. So, think about all the ways that we need to improve that access. And I think that telehealth certainly, not only, but certainly also supporting our EMTs and our first emergency responders, the firefighters. If you go to the Adirondacks, you're going to get a firefighter as your first responder, and they do a pretty darn good job. So we better figure out how to support them and help them. And again, with telehealth, and also thinking about transport. I'm sure a lot of your very sick people have a helicopter on the way, and how can is that working? What do we know about it, and how can we improve that system? So last comment, Troy, you got me talking about something I really care a lot about. I care a lot about a lot, but so 2 examples. And Martha's Vineyard, well, actually Nantucket, both of them. Nantucket, they're both a part of the Mass General Health System, Mass General Brigham. And they just built quite an extensive wing on one of the battles. And the local people said, you should have bought 10 more helicopters. So because they can't get workers, they can't get the healthcare workforce there. And then the second thing I learned when I was in Idaho was this is the phenomena that I heard. They said, if they want to live way out there, that's their fault and their problem. So it was blaming the person, the older person in particular, for choosing to live in a remote area. So there's a lot of elements, there's a lot to unpack, and we need to do that. We need to be a part of the solution. So thanks for mentioning that.
Thank you. I'm going to go to chat next. And we have Joanne Monapar asked a big picture question. There has been great success around many age-friendly efforts, but there are also challenges. What do you see as some of the core challenges that hold institutions, organizations, et cetera, back from considering how they can be more age-friendly?
Yeah, the core challenge for me is depth and stickiness. So for Joint Commission, the way you get a certification is you tell them the story, you write your report, and then they send a team out to go on site and kick the tires, is the way I'm going to explain it. So they'll come to your health system, and they might go to the first 2 units where there's age-friendly banners and people can cite the 4Ms. And then they go to the 3rd and the 4th and they say, I don't know what you're talking about. Right there, we have to talk about the stickiness, depth, and rigor with which we embed this work. And so CVS has done that by embedding it in their electronic health record. And you can't, I don't know how to say it, you can't fast forward through it. If you don't do the 4Ms, you can't move to the next page. And that's not a very friendly thing to do. So in some places would not appreciate that. But I think that all that, so thinking about this work in a way that has embeddedness and a way in which we'll see it in the next 20 years, 40 years, that's the biggest challenge. And I'm always looking for people to give me good ideas.
Thank you so much. So now we're going to go to the audience, and we have Abdul Babar who has a question.
Thank you, and Dr. Fulmer, thank you so much. What an amazing presentation and amazing work. My question regards to newcomers, new Americans who come to this country as refugees. And when I think about age-friendly communities, what comes to mind is belonging. And in my parents and those who are my neighbors that who do not speak English really struggle to connect in this community because of lack of feeling isolated and not being able to drive because they cannot pass, they cannot get a driver's license due to limited English. So what can we do to support those older adults?
You know, that is such an important question, and it drills right down on what we need to do for equity. The first thing that comes to my mind is Project ECHO. And I don't know if you're familiar with that, Mr. Barber, but Project ECHO is at the University of New Mexico. And I bet you Mark and Tim know about it. But Project ECHO uses a strategy where you can overcome some of these barriers across languages by getting the people who can communicate in a native tongue. And it does take some technology. So if technology is a barrier, that's something to weave into the equation. But I think that is one solution. The next one is, and I would love for you to test this for me and tell me how it goes. I personally, this city, we have about, I don't know, 120 languages. And I practice nursing at Mount Sinai as an attending nurse. And I use Google Translate all the time. And I don't know if that's useful to you. Have you been using it?
Depends on the language. So I'm from Somalia, and if you, it's not helpful at all.
Okay, well, there's something for us to work on, because that's unacceptable. But getting a Somali translator and figuring out how to get content delivered appropriately. Maybe it's a public service message with your local television station that says, here are some resources for you. I don't know if that would be useful. I don't know. Is there what would you tell me is the best avenue in to your community? Can you tell me?
I have some ideas, but I don't know if they work.
Well, you got to test ideas, right?
Yeah, exactly true. But I think some of the interpreters are really good, but if you're not speaking for yourself, sometimes it's frustrating for all the adults. And it happened to my mom as well. Like, I was interpreting for her and she got frustrated and she said, I wish I would speak English so I can speak for myself, right? So, trained interpreters who know about age-friendly communities, philosophy will be number one. And number two is working with local community leaders and training them and empowering them to work with the community members.
I think those ideas are strong, and I think that they're feasible, and I look forward to your progress. And if you want to send me an email and tell me any additional thoughts, I'll share them with my friends at IHI. They're global, and they may have friends in Somalia who could be additional help.
That would be awesome. Thank you so much.
Sure.
We have another question from Claire Davenport.
Terry, so good.
Hi, Claire. How are you?
Yeah, we have a friend in common. That would be Tim.
Love it. I love your backdrop. Very nice.
Thanks. Yeah, it's not my view. So I recently become medical director for a large PACE program, and we're trying to address the social determinants of health. And you mentioned social determinants of health in your talk, and I am curious about the direction of age-friendly health systems and the information that we can use to really, number one, just screening for the social determinants and the variability that is in every population. Yep. Is so complicated. And then two, like the intervention that we're selecting right now, it's interesting, sort of like a yes or no. You screen positive for needing this intervention or you don't. And I think that there's probably a lot more to go in this arena. And I'm finding that data is a bit scant. So I'm curious if you have a good direction to sort of send me as we embark on trying to address the social determinants.
Yeah, as we speak, the head of the National PACE program is in our conference room working with Ronnie and introducing the exchange of what you're talking about right now, we've been funding PACE for 30 years out of this organization and are watching the way that the spread and scale is going, but it is clunky. And that's what you're noticing, Claire. And the regulations and the criteria are they're stringent. They don't work for people necessarily. I would say there's this wonderful guy named Cy Francis at Welby. Do you know Welby? Do you know Cy?
I know Welby. We're going to be implementing patient priorities care there.
Good. So Cy Francis is the CEO of that organization, and he is magnificent in terms of his accessibility. If you send him an email, and his email is right on the website, and asked him a question, he would help you. And he's just doing a great job. Let me know how your progress goes. I'll be interested.
Okay, thank you for those questions. And we are almost out of time. And so, Terry, thank you so much for your generosity in answering all of our questions. I do want to bring up a couple of comments that were in chat, and they were negative comments about Medicare Advantage and how they are not necessarily easy or all that well, or easy for patients and families to navigate or provide the type of care that they would like. I would just love to give you an opportunity to say, how can being age-friendly and using the 4Ms framework help these Medicare Advantage plans?
I know that they're tough to navigate, and they're growing, but at the same time, they are overly complex, hard to manage, hard to navigate, lots of ideas, but not necessarily follow through. And so that's hard, not only for those organizations, but certainly for the people they're serving. I believe firmly that if they had a 4M framework, that it would streamline their complexity. It would also reduce the cognitive burden for the patients and families they serve. And we're going to keep at it.
Great, thank you so much. Well, this brings us to the end of our keynote session. Thank you again, Dr. Fulmer, for sharing all of this wonderful and inspirational directions under the age-friendly ecosystem. I think it challenges all of us to do better and to reach out and form those multi-sector collaborations. We are going to take a 15-minute break. And when we come back, we are actually going to do some work in smaller groups to discuss what is going on in our communities? What are the strengths in our communities in regards to being age-friendly? What are the challenges we face? And what are the populations that are really at risk for facing those challenges? So I hope that you will come back in 15 minutes and join us for the next hour. We'll end right at 5 o'clock this afternoon. So we'll see you in 15 minutes, which is 4 p.m. Mountain Standard Time.
Best wishes for your conference.
Thank you so very much.
Thank you, Dr. Fulmer.